Hello everybody and welcome to this session in the Pigmented Lesions E-class. In this lecture, we shall be discussing the acquired tongue disorder of black hairy tongue. Black hairy tongue is typically a complication of some medical condition, or more frequently, a sequela to some of the medications prescribed for the clinical management of these medical conditions. The lecture is going to be guided by a number of visual images because I would prefer you capture the physical appearance of this pathology since the diagnosis is more of a clinical one and histopathology or laboratory tests are not really needed for a confirmation. Throughout the lesson session, you should master the clinical features, the etiology and pathogenesis, and then equally important to understand and become conversant with appropriate management approaches. Before we even get started, I would like to make the distinction between two common hairy pathologies of the tongue. That is black hairy tongue or hairy tongue, which is the topic for today, and then hairy leukoplakia. Hairy leukoplakia is a viral-induced white lesion, mostly but not always seen in HIV-infected individuals, and often prefers to occur on the lateral sides of the tongue bilaterally. It is an opportunistic infection induced by the type 4 human herpes virus. We will have a look at it more into details later on in the white lesions E-class. Now, let's begin with the proper lesson for today. Here is a case of a middle-aged female with black hairy tongue. By definition, black hairy tongue is characterized by the presence of abnormally elongated filiform papillae structures on the dorsum of the tongue and is an acquired epithelial disorder of the oral cavity. To make you understand this better, we will take a look at some normal characteristics and facts about these filiform anatomic structures. I will come back to this case again in a bit. Alright, as you already know from your basic dental science courses, there are 4 lingual papillae: the filiform, the fungiform, the foliate, and then the circumvallate. Whereas the circumvallate and fungiform play direct roles in taste perception because they possess intraepithelial taste buds, the filiform and foliate do not transmit gustatory signals. The filiform, which is the most numerous, confers protection on the tongue thanks to its normal surface keratinization. This keratinized surface imparts a white property to the dorsal tongue surface. This means that to some extent, a white dorsum is considered a normal feature of the tongue, as can be seen in this individual. Any white you see here is filiform papillae, which in their normal state measure between 1 to 3 millimeters in length and lightly coat the tongue surface, as you can see from front to back. They may occasionally get discolored depending on food intake like coffee, colored drinks, and so on, but overall, with gentle tongue brushing, it all goes away and returns to this nice white or whitish pink appearance. The pink dots you see intermixed like here, 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 and here, these are the fungiform papillae, and they are pink because of the relatively increase in subjacent vascularity and the absence of surface keratin. Here is another normal tongue showing more pronounced features. The white structures again will represent the filiform papillae. These will be the fungiforms, and these are some of the circumvallate papillae. About 12 of them are present normally, and they are arranged in a row that roughly demarcates the tongue dorsum into an anterior 2/3 and a posterior 1/3. This is a close view of the filiforms showing off their wispy, cotton-like tufts of white keratin. Normally, the level of this keratin is maintained by a balance between its formation and its desquamation, so that at the end of the spectrum, 2 main pathological situations could result: either an over-retention of keratin or a rapid desquamation that is much faster than the normal replacement and hence resulting in depopulation disorders like erythema migrans, for instance. Have a look at the lecture catalog for the video on erythema migrans. A lack of normal desquamation is what results in the hairy tongue pathology, and it is discolored in this case simply because of staining by either exogenous or endogenous substances. Depending on the color of these substances, a hairy tongue may take on a variety of colors: yellow, brown, green, red, and so on, and in fact, there are even cases that are unpigmented. When it is black, you may come across the term lingua villosa nigra, which is just a Latin way of saying black hairy tongue. Similarly, a yellow hairy tongue will be designated lingua villosa flavum, and so on and so forth. A closer look should make you appreciate the length of these filamentous structures. So essentially, the condition is an overgrowth of filiform papillae. You could actually single out one strand and then trace it from the base up to the tip. Anyways, this short clip is just to hammer home the hair-like texture of these filiforms, because some of you may be thinking the increased conification probably makes them stiff and relatively immobile. No, these are flexible and movable in all directions, and they not only give an unattractive appearance to the tongue, but they may physically irritate areas of the mouth that they come in contact with. Normal filiforms are typically between 1 to 3 mm long, but in hairy tongue, they can be as long as 15 mm or even more. They are painless, as evidenced by the tolerance of manipulation by this patient. Bacteria, candida, and food debris frequently lodges between these hairy fronts and will settle down and remain there for long periods of time. In such instances, they incite local inflammatory changes that may then manifest as oral burning sensations or an established state of secondary glottodynia. For the most part, however, these lesions are asymptomatic, especially in milder forms. Severe and very extensive elongations may cause additional symptomatology, such as gagging or tickling because of soft palatal irritation. Halitosis for obvious reasons. Dysgeusia usually in the form of metallic taste, and occasionally patients may have a feeling of nausea. Here is another case of hairy tongue, and this time with an accompanying dermoscopic view showing the stained filiform hypertrophic changes. If you are not yet conversant with dermoscopy, we have some notes on it in the blog section, and you might want to check this out after this video. I will leave a link below this lecture. The usefulness of dermoscopy is that it is capable of visualizing the exact morphological changes in the filiform papillae, including color changes that may take place. It may also be employed post-therapeutically to non-invasively assess the success of treatment. Here is another clinical dermoscopic view of these filiforms. In between at these sites is where bacteria and fruit debris love to settle, and dermoscopy may be able to demonstrate local signs of inflammation within these areas. Let me emphasize again that the staining that occurs in this pathology can be either exogenous or endogenous, with the endogenous kind typically caused by an overgrowth of chromogenic bacteria, especially the porphyrin-producing black pigmented acyclolytic gram-negative anaerobe, which all of you should be screaming by now as Porphyromonas gingivalis. Alright, now it's time to make another distinction between terminologies: black hairy tongue and black non-hairy tongue, also called melanoglossia. Everything we have said so far relates more to the classic black hairy tongue. Non-hairy black tongue differs by not having elongated filiforms and is indeed sometimes also referred to as pseudo black hairy tongue. Have a look at this case of a 59-year-old African American man. Notice the non-filamentous black discoloration spanning anterior-posteriorly on the dorsal tongue surface. The diagnosis for this case is a simple black tongue, which again may be synonymously referred to as melanoglossia, pseudo black hairy tongue, lingua nigra simplex, or black non-villous tongue. Here is another case. You should be able to tell the difference, especially if I were to put the hairy variant adjacent to it like so. Suffice to say that some of these non-villous discolorations may be actual melanin pigment disorders that may occur developmentally or following certain drug administrations. One difference you may have spotted is that in the classic hairy tongue pathology on the right side here, the discoloration is more central and posterior, whereas in the non-hairy black tongue, the distribution is lateral and more anterior. This is obviously not always the case, but it is a minute clinical detail that you may want to take note of. All in all, however, irrespective of the type of black tongue, the etiologies are similar and likely multifactorial, involving a mix of local and systemic factors. We will look at each of these factors next. For the local factors, extensive and heavy smoking is a huge predisposing factor, and in fact, this is probably why black-headed tongue has an increased prevalence in males compared to females. A poorly maintained oral hygiene will also be a risk factor, especially for those hygiene practices that do not particularly pay attention to brushing of the tongue dorsal surface. This not only allows the keratinized foliforms to elongate, but also facilitates the retention of oral microorganisms like Pseudomonas gingivalis within the conducive niches between these hairy foliforms. As discussed previously, this contributes to genuine halitosis. A poor oral hygiene is especially more likely in individuals who have challenges with manual dexterity. For instance, those with chronic debilitating arthritic disorders and the elderly in general. Also, those with chronic pain syndromes like trigeminal neuralgia or glossopharyngeal neuralgia may hesitate in performing oral hygiene practices. With that said, some other factors like xerostomia may indeed contribute to a poor oral hygiene and ultimately then to hairy tongue pathology. Also, saliva normally contains certain enzymatic factors that aid in the discrimination process, so a reduction in levels will allow retention of keratin and if not corrected will result in hairy tongue among other manifestations. One of the local causes of xerostomia is local head and neck irradiation, and so this is also regarded as a predisposing factor to hairy tongue development. A more common local factor will be the heavy intake of tea or coffee products, as well as chronic soda or alcohol intake, even though some of these contribute more to the exogenous discoloration patterns rather than to the actual hypertrophic process. Nevertheless, a good tongue hygiene in the presence of all these products indeed can attenuate the lesion development. The chronic use of certain mouthwash products having considerable oxidizing properties, especially if used undiluted, will be a significant contributing predisposing factor for hairy tongue development. One of such mouthwashes will be hydrogen peroxide, for instance. Now, this actually sets up a vicious cycle of pathological events because the resulting hairy tongue will lead to halitosis for reasons discussed previously. This halitosis then prompts further use of these mouthwashes with the primary aim of alleviating the malodor, but in reality, it only aggravates the condition. Things are made even worse when their use is not accompanied with mechanical oral hygiene practices. Anyways, other implicated mouthwashes aside hydrogen peroxide are those containing sodium perborate or sodium peroxide when used indiscriminately. In addition to this, the indiscriminate use of local medicaments, herbal preparations, and certain aerosolized medications may all predispose to hairy tongue. One particular culprit is pepto-bismol, implicated mostly in the black non-villous type lesions and is used medically as an antacid to control symptoms of certain gastrointestinal disorders. The chemical pathology involves the metallic element bismuth combining with sulfur compounds released as byproducts of oral bacterial metabolism. The result is bismuth sulfide, which gives the black discoloration to the tongue and usually goes away after cessation of the drug. Now, you do not have to memorize this equation, but just appreciate the process as a basis for the pathogenesis of the disorders. Of further interest, bismuth sulfide may also cause the stool to be black as the drug transits through the gut because colonic organisms also indeed produce sulfur compounds as byproducts as well. Dietary changes, such as soft diet restrictions or prolonged fasting periods, will eliminate the normal abrasive effects of mechanical chewing or beneficial cleansing effect of fiber consumption. These obviously will have a pronounced influence on hairy tongue development. Note that diet restrictions can be for a variety of reasons, such as weight loss purposes, edentulism, or even because of orificial pain syndrome, since chewing may aggravate symptoms in these patients. Systemic predisposing factors will mostly comprise chronic medical conditions and the medications used in treating these conditions. For instance, advanced cancer and cancer chemotherapy, chronic infections, and their respective antibiotic therapies. It is possible that these medications may affect the tongue epithelium in some way, but then their exact contributing role is still largely not well characterized. Some known-implicated medications will include linezolid as an antibiotic, metronidazole as an antibiotic and antipetrozole, certain atypical antipsychotics like olanzapine, tetracyclines like Doxy, pegylated interferon for hepatitis C, and many more medications. The effects of these drugs on hereditary tank development may be produced single-handedly or in combination, so that concomitant use of two drugs, for instance, may result in the disorder, but then monotherapy will probably have no clinical consequence. Anyways, let's move on now to discuss the histopathology of hereditary tank. Unfortunately, I do not have slides to show you because these lesions are readily not biopsied, since their clinical findings are oftentimes pathognomonic. If you were, however, to biopsy them, you will likely find the following characteristic features on the histopathology: hyperkeratosis of the filiform papillae, which of course is the hallmark feature, moderate non-specific inflammation in the lamina propria, overgrowth of candidal hyphal elements, and a variety of bacterial species. You may also see food debris within the meshwork of the hypertrophic filiforms. The food debris serve as substrates for bacteria to degrade and digest, and in the process produce colorful byproducts like porphyrins or volatile sulfur compounds, which may then contribute to halitosis or combine with exogenous substances to form a color precipitate. Despite the fact that we do not readily biopsy these lesions, knowing their histopathological phenotypes can become important, especially when cases present atypically and must be distinguished from potentially sinister pathologies. Speaking of which, one of the most alarming lesions on this list of differential diagnosis is oral acanthosis nigricans, which, like its cutaneous variant, is frequently a paraneoplastic disorder that underlies an undiagnosed malignant disease. The clinical distinguishing feature between this and hereditary tank is that acanthosis nigricans also involves the lips. Now, we've already talked briefly about oral hairy leukoplakia, and it is another alarming lesion, and we said it is a manifestation of some form of immunosuppressive disorder. Tank coating, especially yellow tank coating, is considered a classical sign of diabetes mellitus type 2, and in fact could possibly be used to predict the disease in a number of patients. It probably is just a form of oral candidosis, which in itself is prevalent in uncontrolled or poorly controlled diabetics. That being said, tank coating can also be seen in individuals who have a reduced oral intake, say because of chronic or even acute stomatological diseases like oral ulcers and vestibular disorders, or maybe because of surgery that warrants parenteral feeding or something along those lines. This, like hereditary tank, is also because of the lack of normal tank discrimination in this category of patients. A classic hereditary tank is not seen, but instead what is observed is a thick pseudomembrane covering on the dorsum of the tank. You can appreciate this more in this 5-year-old pediatric patient with primary hepatic gingival stomatitis, who, because of the severe pain and oral discomfort, has not been feeding normally as before. Notice again that the tongue isn't hairy, but instead is rather covered by a thick coat. Here's another view of the same client showing the characteristic coating. Treatment of the underlying disorder and resumption of normal oral function should alleviate the coating almost instantaneously. Obviously, a good oral hygiene will as well be invaluable. It is perhaps worth pointing out that this kind of coating may be easily confused with the non-pigmented variant of hereditary tank. However, notice in this case the wavy tufts of filamentous filiforms, especially in this central region here. One way of confirming this in the clinic is to simply blow some air from your 3-way syringe over the dorsum of the tank, and in the case of hereditary tank, you will observe a cooperative bending wavy movement of these elongated filiforms. With that said, it is not impossible to see the coexistence of both of these lesions in the same patient. The treatment, and therefore the prevention of hereditary tank or pseudo-hereditary tank for that matter, involves 3 main strategies: patient reassurance and motivation, maintenance of a reasonable oral hygiene, and then the modification of predisposing factors in order to prevent recurrence. In the meantime, some active treatment may be performed. For instance, regular tank scraping using a scraper and baking soda preparations, the local application of keratolytics like 1% podophyllene or 30% urea solution or cream, the directional usage of peeling agents like trichloroacetic acid, and then in very extensive cases, surgical trimming of these elongated filiforms. The consumption of certain fruits may also aid the desquamation process. For instance, pineapple is not only rich in roughages, but also contains enzymes that may contribute to the reduction of the height of these filiforms. Note, however, that this bromelain enzyme may indeed also cause sloughing of normal oral mucosa and lead to mouth ulcers, and so you must give precautionary advice to your patients regarding this. Now, one final thing before we complete this lecture, just to show you two variants of hairy tank in terms of color differences. On the left, we have a yellow hairy tank, and on the right, we have a brown hairy tank. Again, many shades of color variations are possible. It all depends on exogenous factors as well as the activity of colonies of chromogenic organisms, also called endogenous factors. This brings us to the end of this lecture, and I'll see you again in the next one.